Guys, this is Mobeen. We're talking about the cardiovascular system embryology. In this series, this is the last lecture. This is the fetal circulation, one of the really important lecture to understand. So let's see what happens. First of all, how do you understand, how do you learn about the fetal circulation? So here are the things to know. Number one must know, I'll write it here, what is the fetal circulation and what are the shunts in it. What shunts are working, number one, and we'll talk about it. What chemical substances are helping, what flow dynamics are present, and then finally what sort of oxygenation and mixture of blood is occurring. So that is to be known for the fetal circulation. Then the second major topic that you should know is that at birth, what are the changes that happen, the changes at birth. And again the same thing, what are the shunts, that what happens to the shunts, what chemical substances are in play, etc., what things, what flow dynamics change, and finally the remnants of fetal components. So this is a of course we can talk about pathology as well, that if there are babies that have problems with their cardiovascular system, then what kind of surgical or chemical interventions we can do. So let's start. Let's look at this diagram. I've made a draft here. So this is the, and this is not the anatomically correct diagram, this is really a conceptual diagram. Here we've gotten a lung, this is another lung, this is of course heart, and if you can't recognize this to be a heart, you need to go back and do more work. This is liver, this is the umbilicus, umbilical, and this is placenta. I've already marked it, placenta. This is bladder. So let's start talking about the fetal circulation. So before the fetal circulation, let's talk about what are the differences of a fetus cardiovascular system compared to an adult. So let me mark those differences. Number one, fetus has a connection with the maternal blood supply. So that is the umbilical artery and vein. So this is umbilical vein, this one. This is the umbilical vein coming from the placenta, bringing blood from the placenta. Then there is umbilical arteries. So this one is umbilical artery. So that is one difference. In the adults, there is no connection with the maternal. There is a psychological connection or physical connection, but not the blood supply connection. So this is one difference. So I'll just put the one here. This is one difference of a fetus from an adult. Second difference is that a fetus has patent foramen ovale. And we have discussed this in detail in the previous lectures, that the septum secundum and septum primum leave a opening through which blood can shunt from the right side to the left side. So it'll be useful to say this is right side and this is the left side. So the blood shunts there. So foramen ovale, that is number two. That is a structure that is different. In adults, this would become fossa ovalis. Number three is this structure you are seeing here. This is the ductus arteriosus. And number four is something you can see here, this one. This is number 4, and that is ductus venosus. So these are the 4 things that are different in a fetus compared to an adult. Now what are the other structures that we can see here? This is the right ventricle, this is left ventricle, right atrium, left atrium, this is inferior vena cava, this is superior vena cava, this one is aorta, this is pulmonary artery, and similarly this is also pulmonary artery. This is aorta, descending aorta, internal iliacs here and here, internal iliac arteries, and we've gotten all the labeling done. So now let's see what is happening. What is the fetal circulation like? First, let's start from here. Number 1, fetal lungs are not functional because fetus is underwater. What that means is fetus is inside the womb, the lungs are solid, they are also filled with the fluids, so there is no chance that fetus would take a breath using the lungs inside the womb. So because lungs are not functional, fetus needs oxygen from some other source. So the other source of oxygen is maternal blood. Now what happens is that fetus has the umbilical vein coming into it. And why do we call it a vein and not an artery if it is bringing oxygenated blood? Because the vessels that bring blood to the heart are called veins, and the vessels that are taking blood away from the heart are called arteries. By that definition, the blood that is coming to the fetus is going towards the heart, and so that is a vein. So umbilical vein brings blood, oxygenated blood from placenta to the fetus. Now how does that happen? Here is a placenta. Although placenta has less oxygenated blood because it is maternal deoxygenated blood, almost deoxygenated, but still it is great for the fetus, and fetus also have, I hope you know, hemoglobin gamma, and that allows it to extract the oxygen even from the lower concentrations of the oxygen present in the maternal deoxygenated blood. So now the blood flows from the placenta. I'm going to use this red, from the placenta in the umbilical vein, and it flows towards the heart, right atrium, through the inferior vena cava. So the first thing to now remember, when the blood reaches near the liver, there is a shunt present here. I'm going to mark this shunt here. This shunt is made by ductus venosus. Ductus venosus opens the umbilical vein into the inferior vena cava, and about 50% of the blood is shunted directly through the ductus venosus into the inferior vena cava. The rest of the 50% goes to the liver sinusoids through, this is the hepatic vein. So the rest of the 50% of the blood goes into the liver, goes through the sinusoids. Why does all the blood not go to the liver? Because it is really slow to pass through the sinusoids and then go back to the heart. So 50% goes to the sinusoids, then finally that blood also opens up through the hepatic veins. It would open up in the inferior vena cava as well. So ultimately all the 100% of the blood would end up in the inferior vena cava. Through that it would reach the right atrium. Now inside the right atrium there are so many dynamics that are happening, but important dynamics are following. The blood that is coming through the inferior vena cava, through its flow dynamics, through its force of flow, would actually continue going and would end up in the left atrium through the foramen ovale. So we have foramen ovale here. That foramen ovale allows the blood to move from the right atrium to the left atrium. It doesn't allow the blood to move from the left to the right because of the septum primum acts as a valve that would close on septum secundum. right? We've done that when we talked about the atrial interseptal development. That lecture should be somewhere over here. So this is the one flow. Now the blood, so the question, this is possible that you can get this question, what is the most oxygenated blood? Where is the most oxygenated blood in the fetus? Of course, umbilical vein, as it enters the fetus, has gotten the most oxygenated blood. Then in the inferior vena cava is the second most oxygenated, because now inferior vena cava above the liver has gotten the oxygenated blood coming from the umbilical vein plus the deoxygenated blood coming from the liver. Then right atrium is the third most oxygenated place. Over there is blood coming through the inferior vena cava, which is oxygenated, lots of oxygen is present in it, and then blood is coming from the head and neck area through the superior vena cava, which is deoxygenated, and that mixture would occur here. So the blood coming from the head and neck is deoxygenated, blood coming from the inferior vena cava is oxygenated. Most of this oxygenated blood would flow to the left atrium. From the left atrium, this blood would go, of course, into the left ventricle, and from the left ventricle through the aorta, it would go towards the body. So body would end up receiving a lots of oxygenated, relatively oxygenated blood through this channel. What is that channel? Umbilical vein, ductus venosus, inferior vena cava, right atrium, left ventricle, and aorta. Cool? Now, the blood that is coming from head and neck, from the upper part of the body through the superior vena cava, that blood mostly falls into the right ventricle. Again, it's a flow dynamic. It's that right atrium and superior vena cava are in line with the right ventricle, so most of the blood just falls into the right ventricle. From here, this blood, deoxygenated blood, it mixed a little bit with the oxygenated blood in the right atrium. This blood through the pulmonary artery here goes towards the lungs. Now here is the important thing to know. Because lungs are solid, because lungs are closed, the capillaries, the arterioles in the lungs are also shut down or constricted. Why are they constricted? So let's look at the chemical substance and the chemical reasoning here. So what happens is that because I'm going to make an alveolus here, because an alveolus is filled with fluid, there is no oxygen, the arteriole present with the alveolus, we know reacts. So this is the arteriole reacts to the hypoxia, which would be generated here, hypoxia, and that hypoxia would constrict the arteriole. So this is the key thing to remember for this lecture. Hypoxia in the lungs causes the lungs arterioles to be constricted. That increases the tension in the lung, so the resistance in the lung is very high. Because of that increased resistance, there are two outcomes. One is that the right ventricle, when the baby is born, right ventricle is actually thicker than the left ventricle, because throughout the embryonic life, right ventricle kept pumping against the resistance. After the birth, this will be reversed in about a month. Why? Because the lungs would expand and the resistance in the pulmonary system would reduce compared to the resistance in the systemic system, where left ventricle is now going to start working against, and due to that, left ventricle would become thicker and the right ventricle would lag behind. But at birth, right ventricle is thicker and stronger than the left ventricle, and one of the reason is the resistance. Now here's the problem. If right ventricle kept working against such resistance, then by the time the baby is born, the heart would actually fail. The right ventricle would fail. The baby would have a cardiomegaly on the right side and baby would have a failed heart. So how do we protect against that? There is this, remember we talked about it in the pharyngeal arch arteries. Sixth pharyngeal arch artery on the left side stays patent stays intact and connects the pulmonary system to aorta. So blood that is pumped from the right ventricle into the pulmonary system actually ends up going to the aorta and into the system. So this one, that is why ductus arteriosus is sitting here, this shunt here is really important. So this is the second shunt you are seeing. The first shunt was ductus venosus, that was shunting the umbilical vein blood into the inferior vena cava, 50%. Here there is another shunt which about 90 to 95% of the blood will be shunted from the pulmonary architecture into the aorta. So that is the second shunt. Third shunt you saw here was the foramen valley. From the right atrium, the blood shunted to the left atrium instead of going as it should from right to the right ventricle. So you are seeing three shunts. You have seen one chemical reason so far, and that is that the resistance in the pulmonary arterioles is high because of the hypoxia present in the lungs. Now there is one more thing here. The ductus arteriosus has also specialized muscles that react very much to, I'm going to write it here, prostaglandins, PGE2, prostacyclins, and that prostaglandin and prostacyclin is released from here. It is released from the ductus venosus. Why is it released? Because of hypoxia. So hypoxia, and that is not lungs hypoxia, it is just because the oxygen levels are low in the baby. So because of the hypoxia, PGE2 is released at the ductus venosus. That PGE2 or prostaglandin acts on the muscles of the ductus venosus and keeps it open. So keeps ductus arteriosus open. Now I want you to form a concept in your mind. If prostaglandins act on the ductus arteriosus and cause it to stay open, then if you give antiprostaglandins, if you give prostaglandin inhibitors, what will happen? Of course the reverse. Prostaglandins would, when they will go away or when you will give the inhibitors, absence of prostaglandins but persistence of hypoxia would cause the reverse action, and that is the closure of the ductus arteriosus. Okay, so prostaglandins and prostaglandin inhibitors, that is NSAIDs, for example, indomethacin and even ibuprofen, the inhibitors will cause ductus arteriosus to close, and prostaglandins would cause the ductus arteriosus to stay open. Now, in addition to that, oxygen also plays a role. Hypoxia keeps the ductus arteriosus closed, and if there is increased oxygen, then the ductus arteriosus hypoxia keeps it open, and above 50 millimeter of mercury oxygen would close it down. So that's about the ductus arteriosus. Continuing with the discussion, now what is happening, one more thing here, the pulmonary veins are bringing the blood back from the lungs to the left atrium, very tiny amount of blood, deoxygenated blood, and so that also gets mixed with the left ventricle, but really insignificant. So that is the fetal circulation. Finally what happens is that as the blood passes through the aorta, it supplies the body, and finally it reaches the internal iliac arteries. Again, about majority of the blood here, instead of going to the rest of the baby, it goes back through the umbilical arteries into the placenta and gets oxygenated again. Now on the way, it also touches the umbilical arteries also touch the bladder, and you would see that later on they'll become the the proximal parts will become the superior vesicular arteries. So this is a closed circuit here. What are the shunts here? Once again, the shunt is ductus venosus, the second shunt is the foramen ovale, the third shunt is ductus arteriosus. Now let's talk about the changes that happen. Let's talk about the changes that happen at birth. Very simple, very cute system that you would see here. What happens is that at the birth, when the baby takes the first breath, that causes the lung to expand, right? So please note it down somewhere. As the lung expands, so does the arterioles and the vasculature expands. So two things are now happening. Number one, the blood vessels are going to be stretched out. That will reduce the resistance or tension in the pulmonary architecture or the vasculature. Secondly, because the breathing has started, oxygen has started coming in, and due to that, the arterioles would open up anyways. So the result of first breathing is lung expansion, reduction in the resistance or in the pulmonary blood vascular system. What would that do? As the reduction, there is the reduction in the pressure in the pulmonary system. Do you think that the blood would now move from the pulmonary to the aorta? No, or it would move less because the pressure is dropping on the pulmonary artery side. At the same time, because there is increased flow to the lungs, that also means that there is going to be increased return into the left side of the heart through the pulmonary veins. So this channel just became hyperactive. This channel, what is this channel? Blood coming in through the pulmonary arteries into the lungs, and then lots of blood going back to the left side of the heart. As soon as that happens, left ventricle is now pumping lots of blood that is going into the aorta, so the aortic pressure would increase. So pressure in aorta increases, blood pressure. Pressure in the pulmonary system reduces, and the result is that this shunt becomes reversed. This shunt, I'm going to make all these changes now in green. This shunt becomes reversed. And now the blood is going from the aorta into the pulmonary architecture or vasculature. Now, consider these 2-3 things. Note them down, please. Number one, at the time of birth, in the beginning of the first breathings, when the lungs are expanding, lungs release bradykinin. Lungs release bradykinin. This bradykinin acts on the ductus arteriosus and causes it to contract. That is one. Second, the oxygen level is increasing now because the baby is breathing. So when there is more than 50 millimeter, not 50%, when there is more than 50 millimeter mercury pressure of oxygen, that also acts on the ductus arteriosus to start constricting it. Third, prostaglandin release would reduce. Why? Because prostaglandins were being released because of hypoxia. There is no more hypoxia, the oxygen is available, so prostaglandin levels would reduce. That also would cause ductus arteriosus to start closing. So all of a sudden what would happen is ductus arteriosus would start constricting. The process there is, please note it down, within few hours it becomes very constricted. Within 24 hours, in about 40% of the people, ductus arteriosus closes completely. Within 48 hours, about 80% of the babies, the ductus arteriosus ends completely, closes completely, and 100% of it closes within 96 hours. If it doesn't, then we have a different problem. Alright, so that is what happens to the ductus arteriosus. Now, check this out. When the ductus arteriosus is closed, now we have gotten higher pressure on the left side. Why? Because there is no more shunting to the aorta, more blood is coming back on the left side. When the more blood is coming back to the left side, what will happen? Second change. Again, look at this. At birth, What happens to the shunts? What happens to the chemical substances? What happens to the flow? So if we're talking about the flow change, number one, ductus arteriosus shunt became reversed. Number two, the chemical substances, prostaglandins reduced, oxygen increased, and bradykinin is released. All this caused ductus arteriosus to close. Now, flow, one more flow dynamic. Increased pressure on the left side will push the septum primum against the septum secundum and keep it closed. So foramen ovale has closed and now it is called fossa ovalis. The floor of the fossa ovalis, if I make it here, if this is the heart, this is the floor of the fossa ovalis. That floor is made by the septum primum, and the ring around that is made by the septum secundum. So the edge is septum secundum. So the second change that came is that the foramen ovale has closed. The closure of that means that the right heart is now connected to the lungs and the left heart is connected to the systemic circulation. Then what happens to the ductus venosus? Now know at birth, within a few minutes, now please remember at birth for a few minutes the umbilical system continues to work and continues to bring the oxygen because the baby is passing through the canal, and so it doesn't just abruptly stop. But after that the umbilical artery and vein, they are severed, they are blocked, they are closed, and that closure would cause the ductus venosus to shut down or become closed. So this would become closed. So this bypass channel, this shunt would shut down as well. So now all shunts have shut down. Ductus arteriosus went away, the foramen ovale went away, and the ductus venosus is gone. That would also mean normal adult circulation has started in the baby. Now let's go to what happens in pathological conditions, what could go wrong and what happens here. So let's look at a few things here. Number one, if the baby has a condition that causes hypoxia, for example, erythroblastosis fetalis, even after the birth baby has anemia, that baby has hypoxia. If that baby has hypoxia, then the ductus arteriosus is not shut down. Why? Because it is open because of the hypoxia, and while low oxygen level causes prostaglandin to be released, prostaglandin act on the musculature and keep it open. So that is one area. Secondly, coarctation of aorta. If there is pre-ductal coarctation of aorta, that would also cause the ductus arteriosus to stay open, and you will actually want it to stay open. So in that case, you would administer the prostaglandins from outside to keep the ductus arteriosus open. If baby does not have the ductus arteriosus closed, but there is no other anomaly you can see and you want to force it to be closed, then you can give the indomethacins or you can give it the ibuprofens. What is the situation where you want to do that? Premature babies. The neonates that are premature would have ductus arteriosus that is open. In such premature neonates, you can give ibuprofen or indomethacin to force the shutdown of the ductus arteriosus. And how do you know that the ductus arteriosus is open? Of course, you know that it's a neonate, it would have a ductus arteriosus that is open. Other than that, you can hear the machinery murmur in the baby as well. So you put the stethoscope on the chest and you hear the machinery murmur, and that you know that the ductus arteriosus is open. Now, what is the importance of ductus venosus? Ductus venosus does not close down immediately after birth. It takes about a month to close down. This ductus venosus is also very useful. Again, if the patient is anemic, if the baby is anemic, he has a problem and you want to give the blood transfusion or blood replacement therapies, you can actually cannulate the ductus venosus from outside and inject a catheter in here and use this route to do the blood replacement therapies. So ductus venosus is actually used in the postnatal life if there is a need for that. Foramen ovale, there are certain cases, and we have talked about those before, no need to repeat them here, but in certain cases you want to keep the foramen ovale open, and for example the transposition of arteries, great arteries, and sometimes you actually make a hole if that foramen ovale has closed, and you do the atrial septoplasty to create a hole, to create the shunt so that the baby doesn't die. So that is done. Now remnants, let's talk about the last topic here, the remnants of these structures. The remnants are simple. Ductus arteriosus becomes ligamentum arteriosus. Ductus venosus becomes ligament teres. Umbilical vein becomes the round ligament of the liver. The umbilical artery, the proximal part becomes a superior vesicular artery, and the dorsal part, the abdominal part, just connects the bladder to the umbilicus and becomes the central umbilical ligament. The fossa foramen ovale becomes the fossa ovalis. Floor is made by the septum primum, and the ridge or the corners or the is the septum secundum. Okay guys, and the final topic is the remnants of the fetal structures. So the remnants are very simple. Ductus venosus becomes ligamentum venosus. Ductus arteriosus becomes ligamentum arteriosus. The umbilical vein becomes the umbilical ligament or ligamentum teres or round ligament. Umbilical artery, proximal part becomes the umbilical superior vesicular artery, and then we got the umbilical ligament, and the foramen ovale, we know it becomes the fossa ovalis. Thank you very much.